Okay, everybody, welcome back to another lecture where we're going to continue our conversation about globalization. And today we're going to focus on something that we've all been experiencing, something very close to home, the relationship between health, disease, and globalization. And particularly, we're going to talk today about the coronavirus, kind of contextualize it within the broader history of pandemics, as you guys listen to in the podcast for today. And then talk a little bit about how anthropologists in particular have thought about issues of disease, globalization, and how to address these issues from a public policy position. So let's start out with a basic question. So in the podcast that you guys listen to for today, medical historian Mark Hannesbaum discusses some of the ways that globalization influenced COVID-19's origins and spread. So what are some of the ways that you learned about in the podcast or that you've thought of to think through this relationship between COVID-19 and globalization? So take a couple moments. If you're in class, we'll be discussing this. If you're watching this, go ahead and skip to the next slide. So as of April 1st, the World Health Organization has reported over 486 million confirmed cases of COVID-19. And to date, over 6 million deaths have been reported to the WHO. If you look at the map behind me, you can see the areas of the world with the highest number of COVID cases. So you see that North America, as well as Central America, parts of Latin America, and then much of kind of Russia and parts of Western Europe are really high on the list of COVID cases. If we kind of break down our data a little bit more, a regional profile indicates that the highest numbers of cumulative cases to date are in Europe, the Americas, and Southeast Asia. So all of this data can be found on the World Health Organization website. So if this is something you're interested in, go ahead and check that out for more specifics on their sample sizes and details about the actual numbers that they have here. So if we can organize the pandemic data by World Bank income, we see that the US, India, and Brazil are all countries with really high GDPs, gross domestic products, and high numbers of COVID cases. These three major countries are followed by places like France, Germany, and the UK. China, where the first cases of coronavirus were reported, actually stands at number 63 on the WHO's list if we rank these cases by country income. So one of the questions that I have for the class is, why do we see really high COVID-19 case reporting in these wealthier countries? In some ways, this is counterintuitive, right? We would expect that wealthier countries will be much better at responding to disease because they simply have better infrastructure to deal with medical emergencies. So why do you think we see this trend? If you're in class, we'll talk about this for a little bit. So some of the reasons why we see this kind of trend in COVID-19 reporting has been kind of documented in a research article by Mohsen Bayati, which was published in 2021. And Bayati analyzed COVID-19 data as it related to per capita income published by the World Bank. So according to Bayati's work, one reason we see this trend is that more developed countries usually have older populations. According to the United Nations 2017 report, about 20 to 25% of the population in Europe and North America are over 60, while the rate is only about 5% in places like Africa or below 15% in a lot of other countries. Because age is a key risk factor for spreading and dying from COVID, developed countries are actually more prone to outbreak of the disease when these sorts of pandemics occur. Another reason why we see these higher rates of COVID-19 cases and deaths in wealthier countries is that in high income countries, there are more resources and better medical infrastructures, which leads to a much larger number of COVID-19 diagnoses tests. So basically, in richer countries, we just have better health infrastructure, so we can do more testing, which means we have more data, more reported cases. Places that have weak infrastructure in poor countries are not able to even address routine population health needs, let alone undertake these extensive kind of documentary and testing efforts that a lot of wealthier nations can do. Another key component that Bayati identifies is that having underlying diseases like diabetes, cardiovascular disease, and other chronic health issues is one of the major risk factors for contracting and dying from COVID-19. There are much more of these specific risk factors in high-income countries than in other ones. For example, the global burden of disease statistics published in 2017 and shown behind me indicates a prevalence of cardiovascular disease in countries with high upper middle and lower middle class incomes. So their data is based on population statistics per 100,000 people. And what they find is that in high and upper middle class countries, there's significantly more people who have these kind of underlying health risks like diabetes and cardiovascular disease than in others. Specifically, you can see about a little over 1,100 cases per 100,000 in high income countries compared to low income countries, which had about a little over 3,000 for every 100,000 people. We also see really similar statistics regarding diabetes based on this report. So in high income countries, we see something like 9,000 for every 100,000 people, whereas in low income countries, we see something closer to 3,500 cases of diabetes for every 100,000 people, right? So that's 3 times as much in high income countries than in low. So some other kind of non-health related factors here that may come into play are the fact that there's just lower air transportation and passenger travel in poor countries compared to developed ones. As a result, the transmission of the virus from places like China, East Asia, and then Europe and the United States to poor countries is much less likely because there's simply just not as much travel between those wealthy countries and poor countries, for example, in Africa. Another big thing here is the issue of data transparency. So countries with the highest prevalence of COVID-19, mainly developed countries, are likely to disseminate the data that they gather more transparently and more accurately. A study by Williams has shown that information transparency had a really positive relationship with countries' income levels. In general, it seems that the more risk factors you have for a disease, along with diagnostic tests, air transportation, and information transparency in high-income countries has led to higher prevalences and deaths from COVID-19 when we compare it to low-income countries. A recent report by the Washington Post has indicated that travel is probably one of the clearest ways to show how the coronavirus has disrupted the world on a global level. In early January of 2020, China placed the first restrictions on global travel. By March, the US had extended its travel ban from China to include most of Europe. As Italy became the epicenter of the pandemic, the EU imposed these broad entry restrictions on non-EU citizens and residents. By April of 2020, global flights had dropped to levels not seen since the 1970s. as nations from Latin America, Africa, and Southeast Asia started to place more restrictions on foreign arrivals. By May, every country in the world had imposed entry restrictions, ushering in a new era of global distance that has had far-reaching impacts on travel, trade, tourism, and economic development. But travel is only one of the ways that COVID-19 has disrupted global interconnectedness. The pandemic has impacted travel like no other event in history. According to the UN World Tourism Organization, 65 countries had borders completely closed to international tourism by spring 2020. Chile's LATM, Colombia's Avianca, Virgin Australia, and Britain's Globe Airlines, have already declared bankruptcy. Analysts predict a year-over-year drop in international tourist arrivals by 80%. The scale of this drop is brought home when we compare it to similar global events. For example, the Great Recession of 2009 led to a travel drop of only 4%, while the SARS pandemic of 2002 led to a travel drop of 0.4%. So this is truly unprecedented in terms of the impact of COVID on global travel, specifically as it relates to tourism. The contraction of the global travel industry has not only hurt businesses like airlines, hotels, and restaurants that benefit from international tourism, but has also impacted environmental conservation efforts. For example, in African nations, tourist dollars have allowed poor nations to maintain large natural preserves that attract visitors. In Namibia, tourism has preserved the world's largest population of black rhinos, for instance. Without new sources of income, these large conservation areas are vulnerable to industrial development projects. National lockdowns have also slowed the flow of people across borders. For instance, on the US-Mexico border, the number of people apprehended and expelled by Border Patrol fell by 47% from March to April of 2020. A little over 15,000 people have been deported, which is the largest one-month drop in 20 years of data collecting by the Pew Research Center. We also see the number of illegal and irregular border crossings along Europe's main migratory routes falling by 75% in April of 2020. All of this data has been collected by international organizations about migration and has shown that a decrease in migration of 48% has happened kind of worldwide from January to April across major checkpoints there's been a drop in migration of 48% across major checkpoints in West and Central Africa. So this is a kind of issue that transcends like the rich-poor country divide. It's not only happening in Europe and the United States, but also in places like Africa. We also see that lockdowns have led to rising levels of unemployment, particularly in low-wage jobs often filled by migrants. As poor migrants languish in unemployment or are forced to return home, the World Bank expects remittances to low and middle-income countries to decline by 20%. This means that more of the world's poorest families will face food insecurity and less access to medicines at a time when they need them the most. While the interconnectedness of national economies has led to prosperity for many countries, interconnectedness also means that economic slowdowns have far-reaching effects on the flow of money, goods, and services. For instance, world trade has fallen by 13% in 2021, which is the steepest drop in over 60 years. Foreign direct investment in things like bridges, roads, factories has also dropped by around 20%. This drop is particularly significant for developing nations who often depend on foreign investment to drive infrastructure projects in emerging markets. For example, reduction of Chinese investment has led to delays in railroad projects in Peru, intended to link the inland farmers and miners in the interior to the Atlantic port and global markets. According to the World Bank, the global economy is suffering its deepest recession since World War II. Up to 100 million people globally are now poised to fall into extreme poverty. So, returning to our kind of subject in the podcast, I'm curious to hear what you guys think some of the differences or similarities are that you noted between the Spanish flu of 1918, over 100 years ago, and COVID. How has globalization changed the experience of these diseases, or what similarities do you see between how these diseases were approached 100 years apart? So we'll talk about this a little bit in class. So successfully addressing global health problems means taking into account different medical systems and ideas of health. One of the first attempts to understand global health problems like the coronavirus was undertaken by medical anthropologists in the 1950s. These scholars created a survey for the Institute of Inter-American Affairs, where they organized a public health program to promote better health in rural Latin American countries. During the 1970s, anthropologists' role in explaining different health systems was largely considered irrelevant to public policymakers, who kind of predicted that there would be this gradual kind of global eradication of major infectious diseases like polio. However, as AIDS and other public health crises erupted worldwide in the 1980s and 90s, medical anthropologists increasingly saw the need to understand both the biological and cultural bases of global health issues in order to create more grounded solutions to these problems. Medical anthropologists have recognized that there are many sophisticated non-Western medicine systems that have been effective for centuries before the US and Europe had developed antibiotics, vaccines, and other modern medicines. As countries like India and China industrialized in the 19th and 20th centuries, they integrated Western medicine into traditional practices. Nearly all societies draw on more than one medical tradition simultaneously. This is what anthropologists call medical pluralism, the coexistence and interpretation of distinct medical traditions with different cultural roots. For example, anthropologist Carolyn Nordstrom did a study of Ayurveda, a traditional medical system developed in India and Sri Lanka. Ayurvedic practitioners diagnose health problems using classic practices of reading the pulse and mixing herbs in specified ways. They also draw on traditional Sinhalese medical ideas and practices, often mixing traditional Sri Lankan herb preparations with those learned at formal Ayurvedic colleges in India. Ayurvedic healers use stethoscopes, thermometers, and dispense Western medications along with their herbal remedies. And as observed by some Sinhalese Buddhist monks, they incorporate principles from Ayurvedic medicine into their therapeutic work. The bigger point here is that in an increasingly globalized world, all medical systems are now plural systems. Medical anthropologists have also played a key role in making sense of how infectious disease spreads within a population. For example, anthropologists have played an important role in helping researchers understand the transmission of HIV, which causes AIDS. In the US and Europe, public health officials responded to HIV spread during the 1980s and 90s by promoting the use of condoms. But promoting condoms hasn't proven as effective in places like Africa and Haiti and other places in Southeastern Asia, which have very different cultures of sexuality and patterns of HIV transmission. By studying patterns of transmission, anthros can help medical researchers understand how culture is shaping HIV transmission. For example, in Africa, HIV was first noticed along major highway routes where long-haul truckers became infected through heterosexual contacts with infected prostitutes, taking the infection to women in the next truck stop down the highway, and so on and so on. Truckers, prostitutes, and truck stops produce ideal conditions for the transmission of HIV through international social networks and economic relationships that transcended national borders. Anthropologist Ezekiel Capellini was one of the first scholars to point out this important connection in 2004. Calipini argues that medical researchers explained the observed distribution of HIV cases in terms of a traditional pattern of African sexuality, which the medical community assumed was really different than the Western world. Basically, public policy folks really demonized traditional African culture and tried to create solutions that would change African culture. While the appearance of modern lifestyles, population growth, things like social inequality, and poverty, which sent African villagers to urban centers and led to the emergence of new forms of employment like trucking, were basically ignored by public policy and health practitioners. Capellini showed that through ethnographic studies in Africa, you could find detailed information about people's ideas about disease and develop explanatory models that actually addressed these broader social, economic, and political contexts around HIV transmission rather than just imposing a one-size-fits-all model of healthcare. An anthropological understanding of global health problems has become more sophisticated as scholars have become more assertive about putting their ideas to work. One way to do this is by working directly with communities to design public health programs to meet their particular needs and cultural expectations. To continue with the HIV crisis example, we can turn to the work of Paul Farmer. Paul Farmer used a holistic perspective to understand how communities and their social problems impacted AIDS in Haiti. Before starting medical school at Harvard in 1983, Paul Farmer spent time in Kange, an extremely poor community in a mountainous area of Haiti. In Kange, Farmer observed the interconnectedness of social, economic, political, and health behaviors before the HIV pandemic had been formally diagnosed in the country. When the AIDS epidemic broke out in the late 1980s, Farmer and his student, Jim Young Kim, helped found a small health center called Partners in Health. While the international community was focused on treating individual patients to slow the spread of AIDS, Farmer and Kim were focused on the larger goals of addressing health in Haiti. They encouraged people to plant trees in previously forested regions devastated from poverty and rapid population growth, which had led to deforestation. They also put together an integrated program that addressed causes of poverty and environmental degradation as a way of improving health overall. After 20 years, Farmer and Kim's program has led to solid improvements in local health and ecological restoration in Kange. In finishing up for today, there are a couple of things that we can draw from all of this anthropological research in thinking about and treating the current COVID-19 pandemic. Effective disease control requires attention to social determinants of health. As Farmer's work shows, it's important to think about social inequality and local culture when we develop community-based models that can address the particular needs of groups rather than applying a one-size-fits-all model of disease control. The anthropology of outbreaks has conclusively shown that stigma and othering also pose serious health hazards during epidemics. We have this tendency to divide our world into us and them categories during times of fear. For example, calling the COVID-19 pandemic a Chinese virus led to harmful actions against Asians that delayed emergency preparedness for the general population. This focus on older people in particular and Asians as risk groups created this false sense of security for people who didn't fit these categories. We see a similar kind of othering process in the United States and Europe in particular during the HIV/AIDS crisis, which was literally called by, as you learned in the podcast, literally called by popular newscasters a quote unquote gay disease. So this public discourse around HIV/AIDS as being only a disease that impacted gay people actually led to severe backlashes and violence against homosexual individuals, which led to actually misunderstandings about transmission and treatment of HIV. Finally, anthropology draws our attention to the need to challenge harmful messages that reinforce social hierarchies, political boundaries, and political boundaries that intensify suffering and death. Responses to COVID-19 by political leaders often focused on controlling certain populations rather than preparing a comprehensive emergency response. As the recent pandemic shows, viruses know no borders, so controlling domestic boundaries is often ineffective at stopping the spread. All right, that's all I have for you today. The D2L quiz answer is that Chaco Canyon is blue. Make sure to fill that out, and I'll see you guys next time.